Hey, good afternoon, everyone. We're going to be starting very shortly. We are just waiting for Dr. Youdelman to join.
Sir.
Hi, Dr. Youdelman.
Well, hello, the future Dr. Ahmed. How are you, sir?
Doing very well. Thank you very much for joining us. We're
It's
going to
my
just
pleasure.
give everyone a few seconds to join on.
Most important thing is that you don't have any dead air space. That makes for poor listening.
Of course.
So you have to come up with something to talk about.
Okay. Oh, you had a clinic today. How was that?
Oh, thank you. It was lovely. I saw one of my favorite patients. She's about 6 years out. Her biggest concern for her surgery was that she has a parrot that lives with her that she feeds with a spoon, and she didn't trust anyone to take care of the parrot while she was in the hospital. And so it took about 2 months to get her to trust her daughter-in-law to take care of the parrot. And every time she comes back to the office, we talk about the parrot for about 15 minutes. And I tell her about her findings on her aortic CT scan, and then she goes home. It's quite entertaining, actually.
What's the parrot's name?
It's very funny that you mentioned that. I actually was thinking to myself that I had never known the parrot's name. Um, and I was going to ask her as she was walking out today, and I got distracted because I was hungry because somebody wanted me to talk on Twitter, so I had to rush and get some dumplings. Now I'm back.
When I see him or her, I'll give them a piece of my mind. All right. So I think we can start because this talk is being recorded. Good afternoon, everyone, and thank you very much for joining us today for our first Aorta Chat interview as part of the TSMA Aortic Disease Awareness Month campaign. My name is Adam Ahmed. I'm a fourth-year student at CUNY, and we're joined today by Dr. Benjamin A. Youdelman of Maimonides. Dr. Youdelman completed a fellowship in cardiothoracic surgery at Drexel, followed by advanced training in endovascular and thoracic aortic surgery at the University of Pennsylvania. He served as the president of the Eastern Cardiothoracic Surgical Society in 2013 and is now the director of Thoracic Aortic Surgery and co-director of the Aortic Center at Maimonides in Brooklyn. Dr. Youdelman, thank you for helping us start off this month of aortic education. How are you doing, sir?
I am well, Adam. Thank you so much. I certainly appreciate it, and I'm happy to participate in these kind of events. I think it's super important, and thank you again for inviting me.
Thank you for being here. So for our very first question, could you please share what inspired you to become a cardio-aortic surgeon?
So if you start with the cardiothoracic side of it, it really had a lot to do with the simple joy that I found taking care of very, very sick patients. I didn't really want to leave my family and my kids in the future to run into the hospital and do something that I didn't think was life-saving or extremely important. And so I liked taking care of sick people. I felt like I was, doing something super important. So it really directed me towards some of the more complex surgical subspecialties. And then, really, in terms of my technical interests, it was really hard to look at any other specialty except for cardiothoracic and transplant, specifically some of the liver surgery I found very intriguing. But I'm colorblind, and every day in the ICU with nurses asking me, did the drains look a little green or a little red? I realized, yeah, I don't think I can do liver surgery, so I'll have to do cardiac surgery. Now, when it gets to aortic, it's kind of interesting. I went to med school to be a pediatrician, which of course makes absolutely no sense now that I'm a cardiac surgeon. But the truth is that's what inspired me, having no doctors in my family before, and really the only doctors who I knew, who I actually liked, were my pediatricians. And I thought that they had a fun job having a good influence on people. So when I decided on cardiothoracic surgery, I was a bit disappointed at not being able to have long-term patients that I was going to enjoy interacting with. And then I saw some aortic surgery, which of course was incredibly intriguing. And then I found out that some surgeons at the time, this is now back in the early 2000s, some surgeons were starting to set up these aortic clinics and aortic centers where they would follow patients for life. So that was pretty exciting. So the combination of it sort of led me to think about aortic surgery once I got into cardiothoracic. And then through a series of very, very lucky and geographically desirable opportunities. I was at Drexel University, which was the old Hahnemann Hospital, and I went to the University of Pennsylvania uh, to work with Larry Kaiser to do thoracic surgery for 6 months. And while I was there, I met Joe Bavaria and I was on call and I did cases with him and I became very intrigued with those operations. And one thing led to another, and I wound up going back for a truncated fellowship, and then the rest is history.
Wonderful. I think something a lot of students don't think about is that long-term connection you form with aortic surgery patients. Um, in your experiences, Dr. Udeman, how do you guide patients who come to you and might be fearful or hesitant about undergoing open heart and aortic surgery?
Well, what I tell people very clearly is that whatever has been acutely found, or as we like to say, the acute findings of chronic disease, those things are present in your body for many, many years. And now you're staring at someone who's telling you a little bit more about it, but it's actually been there for many, many years. And it may have been inside your parents and grandparents and things of this nature. I think fear of pretty much everything like this comes from the thought process that the physicians are not telling you something that you should know, or that they don't want to tell you something because they think you'll get too scared. And I think if you create a posture of absolute unrelenting honesty with them and telling them the meat and potatoes of the risks and benefits of surgery or non-operative management, and then telling them, listen, there's a lot to talk about and we can talk all day, but these are the things you need to know. Um, and I do think that just being incredibly open and honest with them allows them to just approach it head on. A lot of the fear has to do with expectation management. Anybody on the call or listening who's married knows what expectation management means. And you have to create a scenario where the person that you're talking to has an expectation for all the good and all the bad things that are about to come out of your mouth. And if they know that ahead of time, I do believe it brings the fear down to an appropriate level. A worry is more appropriate, concern is more appropriate, but fear is just an exaggerated, unnecessary emotion that comes up with all of these patients all the time. But I do think it's incredibly important that we do our very best to just be very honest with them. And then the second thing that I do, which I think is critical, is to explain to them that we have a very robust group that is formed both of patients, families, and caretakers and healthcare providers who they can talk to and interact with on a regular basis and get someone who actually knows what they're feeling in a conversation so they can get from point A to point B. You walk home with a diagnosis of aortic aneurysm to a group of people who love you more than life itself, but absolutely cannot relate to anything that just happened to you in the office with your physician. And so it's critical to have these um, support groups and organizations to allow patients to talk to people who are going through the same thing that they're going through.
Thank you, Dr. Udeman. Oh, and in your experiences, helping patients and connecting them. What are some things you found, or rather, what is something you wish more people knew about aortic disease?
Well, the number one thing that I really want everybody to know, and especially everybody on this call, is that all that you learn in medical school about so many things is designed for them to test you, but it's not necessarily the truth and it's not necessarily accurate. And so much of it is incredibly behind in terms of the knowledge that is available on most of the topics. And that's not a ding against the medical schools. That's just a ding against the way things are taught. The number one thing is that 80 to 85% of the patients who have an aortic dissection, aortic rupture, or aortic aneurysm have absolutely no physical attributes, no genetic markers, no history of anything that has anything to do with a concern for aortic surgery or aortic disease or aortic problems in their history. And that what we learn about in medical school with all the named syndromes are a paucity of the cases that all of us see on a regular basis. And I joke that those syndromes have better marketing and public relations people than the non-syndromic cases of aortic disease. But the problem I have is here's the scenario. A person who's 6'4", 180 pounds, walks into the emergency department with chest pain and tells a story that they have a father and a mother and a brother and an uncle who had coronary artery bypass grafting surgery. The emergency department physician will immediately think the patient's having an aortic dissection and delay their sending them to the cath lab and sending them to the CAT scanner because they're tall and thin. And by the same token, a 5'4", 300-pound man who comes in saying that their brother, father, and mother and uncle had an aortic dissection or spontaneous aortic rupture or unexplained sudden death or previous aortic surgery or aortic valve surgery, those people are delayed, sent to the cath lab, some of whom, I'm sorry, will die on the table as the cardiac catheterization is performed on a type A aortic dissection. These are the prejudice of the medical communities that are started in medical school that I implore all of you to work very, very hard to combat. Because as we start to open our eyes to the fact that most of the patients with aortic disease do not look like anything in particular, do not have a particular weight or height or any of these things, we will save more lives, identify more patients, and be able to do more elective surgery and avoid more emergent surgery.
Thank you, Dr. Youdelman, for explaining that. And I think that's the importance of having experienced speakers as yourself come and share this with us. Um, could you tell us a little bit about your experiences at the Aorta Center at Maimonides and speak to the importance of multidisciplinary collaboration when managing these patients?
It is critical as we move forward with our respective fields that we realize the absolute value that each of us bring to a multidisciplinary group. It is not the case that every person is bringing everything to every meeting, but there's no question that most aortic centers are a combination of cardiothoracic surgery, vascular surgery, and plus minus the following, either interventional radiology, there are cardiologists, of course, and there are some other specialties that are at play. When we meet every week on Wednesday morning for our aortic center meeting, it is because we are reviewing the cases for the following week, meaning it's Wednesday, cases are Monday through Friday, at least the elective cases are. and we discuss the complex aortic cases and what needs to be done and what's going to be done. The vascular surgeons bring the expertise of the newest and latest technology that's being applied to both the arch and the periphery and the femoral arteries and the aortic center conferences, which often hinge on we can do this better and we can do this better and we can do that better. All that stuff needs to wash away and take each of these patients as individuals. I'll give you two examples. One, I have a patient who I did an aortic dissection on many, many years ago, and he was very fearful of surgery because he was having a enlarging residual type B dissection. He pushed off doing a thoraco when that's all we really had. He then pushed off doing an arch frozen elephant trunk because that's all we really had. And in the last year, because we now have the thoracic branch grafts available, I, with my vascular chief, got together and did extra anatomic arch bypass and a zone zero bypass. Zone zero total arch replacement on this gentleman. And he himself, and I've been joking that he, through his fear of open surgery, actually got to the point where he could have a more successful and less invasive outcome, and he's doing extremely well. These are the type of things that are only able to be done if people relinquish the responsibility of, I can do everything great, and I can do this great, I can do that great. The discussion about how to do his surgery and when to do his surgery and what to do hinged on what was available technologically. And now that we're able to do some more advanced work, we can look at patients individually and say, you know what? This 75-year-old residual type B dissection probably should not have a redo total arch frozen elephant trunk followed by multiple descending thoracic aortic stent grafts. You know, these are the type of conversations that are only available in multidisciplinary collaborations.
And more to that point, Dr. Youdelman, as you collaborate and as new technologies arise, how do you balance the introduction of new techniques and innovative methods with perhaps more time-tested principles of aortic surgery?
Well, that's actually a very, very challenging topic because while the multidisciplinary collaborations always benefit the patient, there is always the need for equipoise when we're looking at these new technologies and new techniques with old technology and saying, hey, wait, we have to compare that to what's always been done. And I do think that within the confines of the two classic multidisciplinary groups that I am very much involved in, one being the collaboration with cardiology on the coronary valve TAVR cabbage PCI side, and with vascular surgery on the complex endovascular aortic branch side. I think that it's very clear that the surgeons have always compared the evolving technology that has been delivered to the cardiologists and delivered to the vascular surgeons with the comparison back to the classic operations. And I think that we have unfortunately dug ourselves in a little bit deep sometimes with some of this aortic work, and it's forced us to push forward a little bit. I think there have been some very classic lines at some cardiothoracic surgery meetings, the best of which was after the first thoraco was first total endothoraco was presented about 20 years ago. The question was, can anybody die with dignity anymore in the United States? The answer actually is, well, that's not the best response to a piece of technology that, when applied appropriately, is going to help a bunch of people. And the surgeon who actually said that has actually changed course a little bit, and is very appreciative of what these advances in technology has brought us. It's just a matter of having the equipoise to roll it out appropriately.
Absolutely. Thank you, Dr. Youdelman. And for our last question, I know you're involved with several initiatives for aortic disease awareness and patient advocacy. For our students on the line and those who listen to the recording, how would you advise us to get involved this month of September of aortic disease awareness?
Well, I think that you know, the number one thing that everybody can do would be to connect with some of your local groups regarding aortic awareness. There are three levels of connection. The national group called Aortic Hope has been a tremendous supporter of patients who are undergoing aortic surgery, classically aortic dissection in hospital, receiving, emails and receiving care packages and things of this nature. And then the international advocacy group called Think Aorta really has started to move into more and more countries. And as you know, I'm very involved with that group. We just had a very, very nice conversation with the leadership in the European Association. And our conversations really hinge on the fact that we're trying to make each of the countries allow Think Aorta to come in and be what it needs to be in these countries. One of the conversations that are going to take place in Edinburgh is that how do we bring Think Aorta to some of the African countries who are underdeveloped, where it's a challenge to follow people when aortic disease is identified, and how it's difficult to figure out what we can do in order to help these situations. These are extremely challenging questions. But in terms of your local advocacy, I think everything starts with you at your hospital or medical school talking to the surgeons in cardiothoracic surgery and vascular surgery who are doing abdominal aortic surgery, thoracic surgery, arch and proximal work, and talking to them about how are they screening the patients who come in with a dealing with patients who come in with a significant family history of rupture but a normal sized aorta? How are they approaching the community of recovering patients from type A dissection and the patients with type B dissection that are home worrying? Creating a situation where you start a conversation with your local surgeons and group. And if their response to these questions is, we don't do that, or that's a great idea, or I'm not sure, well, any of you can reach out to me by email, and I can certainly connect you with the appropriate people to start a conversation. But more importantly, it starts people talking and communicating about what we all know, which is once you have patients and family members understanding that any one person in the family who gets heart attack, stroke, diabetes, cancer, and aortic disease, then they should be on the lookout for this recurring in their family. I don't really care that they only think about aortic disease, but I do think that it's important that they have to think family when they think about the aorta and when they think about all of these other disease processes, and realize that we're all governed by our own genetics and that we have to be very, very respectful of what we're given by our parents.
Sure. Thank you very much for sharing all those groups. And I just have to ask you, I noticed you're speaking today from an account called Aortic Bridge. Could you share a little bit of information about that for students in the New York area?
Absolutely, absolutely. So aortic bridge, when I got to Maimonides Medical Center in Brooklyn, and set up our aortic center here with Dr. Rob Ree, the chief of vascular surgery, we realized that there was no such group in the New York metropolitan area. And so we started the local group. Obviously, we're in New York, there's a lot of bridges. We're in Brooklyn, the iconic Brooklyn Bridge, of course. And so we do all of the advocacy and all of the communication through our local group. And this is for multiple activities. We used to do more before COVID. And right now we are setting up for our September 15th aortic bridge walk, which we go across the Brooklyn Bridge and back. And then we all meet and break bread and sit together and allow the families and the patients and the practitioners to talk. And it really is a very special yearly event, celebration of life and celebration of these patients and their families. So aortic bridge is just the introduction into these national and international societies, and that's our local group.
That's wonderful. So, for any of our students in the area, please be on the lookout for the registration link after. Dr. Youdelman, we are approaching 4:30 Eastern times, and we do want to be respectful of your time, but really we appreciate all the insights you shared with us today and these wonderful resources. Do you have any closing remarks for our students today?
The one thing I really think that the students really have to think about with regards to cardiothoracic surgery training and certainly aortic surgery training is you are not going to come out of your medical school residency if you do a 5-2 or 5-3 program or your I-6 program ready for prime time. You're going to come out with knowledge, ideas, a set of skills that you've learned from one group of people, and be patient and be kind to yourself and give yourself the 3, 5, 7 years to figure out what you want to be and how you want to do things, and be patient, because unfortunately the reality of it is that the work hours and all of the things that have changed the way residency training is detracts from your opportunities, and that has to be made up for in the first few years of your work life. So just be patient with yourself. It comes in time, and you're going to be great. And obviously, we're all around here to help you out in any way we can.
Thank you very much for saying that. All right, on behalf of everyone online today and the rest of the TSA community, thank you all for joining us for our first Aortic Disease Awareness Month interview with Dr. Ben Youdelman. Please be sure to join us Sunday morning for our first survivor interview on Twitter Space as well. Thank you, everybody. Thank you, Dr. Youdelman.
Thank you.